Bismillahirrahmanirrahim. In this lecture, we will study the hoarseness and its management. Now, first, we should understand that there are certain prerequisites for the normal voice production. Once we understand this phenomena, then we will be able to understand the hoarseness and its management. The prerequisites are: number one is that the vocal cords should approximate properly with each other. Secondly, they should have proper size and stiffness. And lastly, they should have ability to vibrate regularly in response to air quality. Therefore, the hoarseness may be due to loss of approximation, for example, due to vocal cord paralysis, vocal cord fixation, and if a tumor coming in between the vocal cords. Then hoarseness may be due to increased size of the vocal cords, for example, due to edema, vocal cord tumor. Similarly, decreased size of the vocal cord may also lead to hoarseness. For example, partial surgical excision of the cord, fibrosis after inflammation or trauma. Similarly, increased stiffness of the vocal cords due to fibrosis or spastic dysphonia. And the hoarseness may be due to decreased stiffness of the vocal cords, for example, vocal cord paralysis. Now, we will discuss the etiology of hoarseness. The hoarseness may be caused due to certain congenital causes, or the cause may be acquired one. First, the congenital causes. The congenital causes leading to hoarseness are laryngeal web, laryngeal cyst, laryngocele, and congenital laryngeal paralysis. Now, acquired causes causing hoarseness. These are: number one, inflammation. It may be acute inflammation or it may be chronic inflammation. And chronic inflammation may be subdivided into specific and non-specific. The acute inflammation in the form of acute laryngitis, usually following cold, influenza, symptomatic fever, laryngotracheobronchitis, and diphtheria. The chronic specific inflammations, for example, tuberculosis, syphilis, scleroma, and fungal infections. Similarly, certain non-specific chronic inflammations of the larynx, for example, chronic laryngitis, atrophic laryngitis. Number two, tumors, benign as well as malignant ones. Benign, for example, papilloma, meningioma, chondroma, fibroma, and sometimes leukoplakia, affecting the vocal cords, may lead to hoarseness. The malignant tumors, for example, carcinoma of the larynx, especially involving the vocal cords. Third, tumor-like masses, for example, vocal nodules, vocal polyp, angiofibroma, amyloid tumor, contact ulcer, laryngocele. Similarly, trauma may lead to hoarseness due to submucosal hemorrhage, laryngeal trauma, foreign bodies, or intubation. Paralysis of the vocal cords, especially paralysis of recurrent laryngeal nerve, superior laryngeal nerve, or both. Similarly, fixation of the cords due to arthritis, fixation of the cricoarytenoid joints. The patient may have hoarseness due to functional causes, especially hysterical aphonia. Then there are certain miscellaneous causes which cause hoarseness, for example, dysphonia, plica, ventricularis, mixed edema, and gout. This is the photograph showing you the juvenile papillomatosis affecting the vocal cords leading to hoarseness. This is the cancer of the vocal cords. This vocal nodules. This is a vocal polyp. This is the photograph showing bilateral abductor paralysis. This is congenital laryngeal web. Now, the management of hoarseness. The management includes history, physical examination, then investigations, and the end, according to the etiology causing the hoarseness, treat the cause. First, the history. In the history, one must ask from the patient regarding the mode of onset of hoarseness, duration of illness, patient's occupation, habits, and associated complaints. Any hoarseness persisting for more than 3 weeks needs examination of the larynx. Malignancy must be excluded in patients above 40 years of age. Second, indirect laryngoscopy. Many of the local laryngeal causes can be diagnosed by this simple maneuver, indirect laryngoscopy. Then examination of the neck, chest, cardiovascular, and neurological systems for laryngeal paralysis. This is the photograph showing you indirect laryngoscopy. Then labs investigations and radiological examination. This will also help to diagnose certain conditions. Direct laryngoscopy and microlaryngoscopy is also needed for detailed examination, biopsy of the lesions, and assessment of the mobility of cricoarachnoid joints. Bronchoscopy and esophagoscopy in cases of paralytic lesions of the cord to exclude malignancy. Then lastly, the treatment. Treatment is that find the cause and treat that cause to treat the hoarseness. Now, certain words about dysphonia, plica ventricularis, also known as ventricular dysphonia. This disease, in this disease, the voice production is by the ventricular bands, not by the true vocal cords. False cords take over the function of the true vocal cords in this lesion. The characteristic of the voice is that voice is rough, it is low pitched, and it is unpleasant. Ventricular voice may be secondary to impaired function of the true vocal cords such as paralysis, fixation, surgical excision of germs. Ventricular bands in these situations try to compensate or assume the phonetic function of the true vocal cords. In functional type of ventricular dysphonia, this dysphonia will be seen in normal larynx. Usually, the cause is a psychogenic one. Initially, the voice of the patient is normal, but soon it becomes rough when the false cords take over the function of the true vocal cords. Diagnosis is by performing indirect laryngoscopy and by fiber optic laryngoscopy. Treatment is treatment will depend upon the cause. If due to laryngeal cause, then it is very difficult to be treated, but the speech therapy may be tried to treat the lesion. If it is a functional type, then psychological counseling and speech therapy is the treatment for this deal. And lastly, a few words about functional aphonia, or also known as hysterical aphonia. In this condition, there is sudden complete loss of voice, which is usually seen in young females. Etiology is usually emotional social problems. There is history of anxiety in the patient, and the age of the patient is usually between 15 to 30 years of age. Clinical features: there is sudden and complete loss of voice. The whisper, cough, laugh, and cry all are normal in these patients. There is no aspiration at all, which differentiates it from adductor paralysis. There is muteness as well. The patient will refuse to speak. The signs are: if you examine the vocal cords will be in abducted position, but on adduct, but they adduct on cuff. So the cuff reflex is seen in these patients. Treatment is just reassurance and psychotherapy. Thank you very much. चलो, लेक्चर पूरी हो गया.